Welcome to the Back in Action podcast, where you're going to hear from me, a spine physician, Dr. John Lavelle, and two coaches, Dusty Holden and Josh Bunch. We're going to help you rethink pain, rebuild strength, and regain function so you can get back to enjoying the things you love in life without limits.
Back in Action, Josh here with Coach Dusty. Welcome, sir.
Hey, man.
It's good to see you.
You too.
Also with Dr. John Lavelle. Doctor, welcome.
Welcome.
I appreciate you
Good
being
to
here.
see you guys.
Yeah, man.
Last time we left the conversation talking about fear. Fear as it relates to what we do. Obviously, we coach athletes and work with athletes. Obviously, you work with patients. But I wanted to get your frame of mind on how fear works and how it plays into recovery, and then shift it over to you, Dusty, and talk about how does what Dr. Lavelle says transform as it makes our way into the gym, into life, and into functionality.
Yeah.
So if you would, sir, just kind of starting out, am I afraid? Am I the thing that's afraid, or is there fear? Tell me sort of how fear works. I know that's
Yeah.
super that's a lot of philosophy.
No, it's a good topic.
It's a lot of philosophy.
I mean, I would say pain is so much driven by fear. And that's when I see patients, you guys see the patients that I send you, most of them, I would say, have some fear that they're going to re-injure. They don't, if they've had acute back pain, acute radicular pain down the arm or leg, they don't want to get back to that spot. Or if they're in that spot, they're worried, I'm just going to keep making it worse. What am I damaging? And I think this is one of the most important topics we'll discuss throughout this podcast, because getting people out of that fear is the most important thing you can get for them to recover, because they won't recover if they're still in that fear. And so what drives that? So let's say a 45-year-old dad comes in the office, sees me complaining of just acute back pain, no radicular symptoms, just across the back. But he's seen me after seeing his primary care physician 3 months ago. Didn't have any injury, just got up out of bed, back was tight. Didn't do anything crazy the couple days before, just back started hurting him. Maybe he had some instances of back pain in his past, but woke up that morning, back was excruciating. So he laid in bed, didn't want to move that day, didn't go to work. So right away, he's setting up his brain that if I move, I'm going to worsen the pain from day one. So then he goes to an urgent care, let's say. They take some x-rays, everything looks good, follows up with his primary care physician a week later. Still having, 8 out of 10 pain, hasn't gone to work that week because just doesn't know what's going on, just doesn't have the knowledge. Completely understandable. You think pain, something's wrong, I got to stop doing anything that would make that pain. And if it's your low back, pretty much every movement's going to worsen it. Sees his primary care physician, they say, well, just rest, move a little bit, but you don't want to bend, you don't want to lift things. And he works construction, so now what can he do? So he calls into work again, they don't have light duty, he's just staying home, sees me, let's say he doesn't even see me yet. He sees an orthopedic physician, just a general sports medicine. They start him in physical therapy. So still not working, but physical therapy just says, well, it hurts when you bend, don't bend. Don't bend at the waist, don't lift things. We're just going to do some simple exercises on the floor, maybe have you do some extension type movements.
Bird dogs, dead
Bird
dogs,
dogs, things like if they get to that.
Yeah.
So what it
Usually.
sounds like is, so far what you've described, and correct me if I'm wrong, it sounds like the thing happened, and then all of the things that are typically surrounding the thing are reinforcing fear.
Correct.
Okay.
And we introduce avoidance.
100%. So we're limiting what he can do. Because now he's limited what he can do, so now he's fearful that if he does any of that stuff, the pain's going to persist or get worse. And so what's happening physiologically in the brain, and this is the key point, is yes, the patient sees all this. If I bend, I'm going to make my back pain worse, because that's been reinforced along the way here over now 3 months. But what's happening physiologically in his body? So when people hear, oh, it's all in your head, or doctors say, everything's fine, your back looks good, that x-ray was fine, maybe he's even had an MRI and everything looks pretty good, maybe some little disc degeneration that we all get, but no real structural reason to have that pain. It's because it's no longer a structural cause. He might have tweaked that back getting out of bed wrong, or maybe that was just the time when that back was going to flare up. But structurally, everything's sound for him to move and not be fearful of that movement. But during those 2-3 months, while he's just had that reinforcement of not to bend, not to lift, not to work, you have that cortisol response in your body because you're starting to get fearful. So we can go really deep in the weeds here, but I'll try to keep it light. So as that cortisol is released, your amygdala, which is in your brain, is the fight or flight. So that fight or flight is then receiving that cortisol that's being released from your adrenal glands. So cortisol is what stimulates us. If we see a dog attacking us, we get a rush of cortisol, we're running. Same thing with on a smaller scale. If you see a heavy box and you got to lift it, that cortisol release goes to the amygdala, and then you have this, well, I can't do that. So you start to develop that fear. And as you constantly propagate that with everyone reinforcing that cortisol is constantly being released. The amygdala becomes hyperactive, so you constantly have that fear. So now it goes away from there's no structural changes orthopedically in the bones, muscles, tissues in the spine, but there is a physiological response in your brain causing that fear and causing that heightened fear. So then you're scared to move and be active. So there is a structural change that's going on, but nothing an orthopedic pain doctor is going to fix with a procedure.
So this is non-mechanistic for the most part, and this is a central sensitization where
100%.
everything feels threat, or basically my mood or my experience, my opinion of this thing now makes that thing a reality. I'm still truly in pain.
Because your brain is what processes that pain.
Got it.
So pain is, if you cut your finger, the pain isn't the cut in the finger. That cut produces inflammation, and your nerves pick up that inflammation, send it to the brain, and that's where you process pain. So you may not have a structural change, but your brain can still be processing pain because of one simple thing, that fear avoidance. So with that cortisol release from the adrenals, similar as if you cut your finger, that fight or flight response, your amygdala is working, and then when that amygdala gets hyperactive, you're not moving, so you have that fear from your amygdala response, which is part of that in the central part of the brain. Then if you're not moving, not going to work, not having that social connection, well, what happens? You become depressed. You get sad. You feel like hopelessness. So then other parts of your brain, prefrontal cortex, periductal gray area, starts to shrink. So you have less serotonin, dopamine, norepinephrine. Some of those chemicals work on the descending pain pathway to decrease pain, but also the prefrontal cortex affects your emotions, how you can emotionally respond to that pain appropriately. So let's say you realize there's a box on the floor that you've been told not to lift. You get that cortisol rush, your amygdala tells you, well, this is too scary, don't lift it up. If it was a normal setting, it had just happened that day, your prefrontal cortex would then activate and say, oh no, this is not that bad, you can still lift it, there's no harm here. But if you have some depression and stress because of all these months of it propagating, well, then your prefrontal cortex has shrunk some, it's not working appropriately, so you don't override that fear response, and it just keeps propagating down the road.
So one of the things that we do to combat that is what you just did. You take some sort of patient and you educate them, right? So you need to...
If you don't do that part, you're never going to get better.
You need to know that. You need to know that you're not... I understand that you're not faking it is the first piece. That if you're truly in pain...
Validate what
the
they're
pain
doing.
is real. This sucks. It's nothing structural I'm going to fix, but I'm going to teach you how we can fix your nervous system, your brain response that keeps telling you you're in pain.
And also it's the perception that you have of it, though. Right, so the self-fulfilling prophecy is me looking at things and then surrounding myself with people that are saying this is bad, and then I just keep getting more and more in my own head about it.
Because it truly is in your brain because of that increased stress of people constantly telling you, basically that feeding in, telling you, yes, don't do this, don't do that, feeds in. That's where the depression and stress of it all sets in. And that's where your mood actually changes because of your prefrontal cortex. And there's other areas of the brain too, but we could spend hours on that.
Sure. Sure.
So then last piece is, so what if you're not moving? Then what else happens? Well, then, as you just mentioned, your nervous system actually becomes sensitized. The pain pathways become sensitized. So when you're not moving a lot, you get increased inflammation. Different cytokines are released, like IL-6. So that actually sensitizes the nerves in that, let's say it's your back, or I use the cutting of the finger. So you don't have a cut there, but your nerves may be sensitized there because of that increased cytokines.
Is this something like a cortical smudging kind of thing? This is why like it started as my back hurting, and all of a sudden it's like, man, my shoulder hurts.
100%.
And
So
then, like, you can't even really pinpoint. You're just, dude, I hurt.
When you get an increased inflammation in cytokines, and then your nerves are sensitive, just light touch can irritate you, or a little scrape, or just simple movement where structurally your shoulder's sound, but that simple movement hits that pain threshold because the nervous system's threshold is lower or is more sensitive.
Yeah. So the take-home message for somebody that's watching that's in pain, they said, well, it started in the back, now it's this thing. They think they're falling apart.
Yeah. You hear that all the time. Getting older sucks.
Yeah. Okay. Now, is it most common or is it worse? Two different questions, I guess, when it happens in the back. So, for instance, what I'm saying is, if I busted my knee, or if I thought it was my knee, but it really wasn't, didn't show anything mechanistic, is that easier to overcome than, say, something that I feel in my lower back?
Not necessarily.
Okay.
So I would say it just depends who they started that conversation with.
Okay.
And
so if it wasn't somebody like yourself who knew the education, and it was, oh, you probably shouldn't move.
Right.
Oh, you probably should sit down.
I think we see it more in the back because everyone's scared of their spine. The spine is what we think is controlling our body, and it is. That's where our nerves are traveling through. So even physicians, other clinicians are very scared or hesitant to say it's okay to move, especially initially, because they themselves don't have that education really of what I just spoke about. So they're fearful to say go ahead, because then, whoa, what if I get sued?
And they're not a movement expert. So it would be remiss for me to say something that you should recommend, and then in the same way that you might not want to recommend, go deadlift, because you yourself might not necessarily know.
So then everybody defaults back to rest.
Right.
Exactly.
Because that's the safest
and now
place
nowadays they know rest is bad, so they'll say, oh, you can do a little bit, but don't do this, don't do that. So if you tell someone not to lift, how the hell do you live? How can you tie your shoes, lift up your purse, lift your kid off the ground? Any hands. Sit down is bending forward.
Yeah.
You shouldn't sit.
Get in your car. I mean, that's pretty common.
Yeah.
It's not.
So then if you have that in your back of your brain, that's constantly affecting that whole system we just touched upon briefly. And that's why they get in that chronic pain, whether it's the knee, shoulder, back. But like you said, the back is more common because people are fearful of that.
You were talking about the back, and you said a few minutes ago that we all sort of have a degeneration of some sort, or we will. And I read the other day, and these statistics are always different, that by the time we're 80, 95% or so, people have some sort of degeneration going on.
I would say by the time you're 20, I could tell you there's something wrong in your back.
If that's the case, if it is wrong, or if it is considered a pathology and everybody has it, how do we even consider it a pathology? Isn't it just normal?
Yeah, absolutely.
At what point do we just call it normal?
It's life. Gray hairs, we don't consider that a pathology.
Well, how does somebody differentiate between their back being sore and then there being something that's pain that maybe requires attention?
Right, and that's where it gets tricky. So you got to go down that assessment pathway, because usually back pain, 80% of the time, in 2 to 6 weeks is going to resolve. Mm-hmm. So if you just encourage someone from day one, as long as they don't have bowel or bladder changes, drop foot, even that, you don't necessarily have to run into surgery if you have weakness in your leg. That's just nerve root irritation most of the time, and it's going to improve. But you want to rule out those red flags. So, bowel, bladder issues, compressing a nerve, you might have a major stenosis or disc herniation or rupture in there that's causing some nerve injury.
Yeah,
so
those are the big red flags.
But you can do all that with a simple exam.
Okay.
That's the hard part. Are we going to examine patients anymore? I mean, this conversation we had has been, 10 minutes?
Yeah.
But you get reimbursed much more if you get an MRI and you get reimbursement from the MRI you're sending to or the injection.
Yeah.
So it's the whole healthcare model needs to change so we can have time with patients to educate. But with friggin' insurances, that's not going to happen anytime soon.
Okay. So when an athlete comes to you, and we've sort of gotten around to where it's chronic. So we would probably consider acute something I just did. I just did something. The thing blows up, whatever that thing is. And it's so much that you would say, let the thing calm down, or at that point in time, it's more reactive, right? So we want to move as much as possible, but not move into irritation. Would we agree that that's an acute
So I think that would be the
situation?
next step. I educate them, tell them all we've talked about here, why it's safe to move. And they'll always ask me, so I can do, I can work? I can absolutely go do what you can tolerate, is how I always say it. Be as active as you can tolerate. But
So
there's no movement that's going to injure you.
Okay, that's a good point. So then my next thing is I come to you and I'm in 5 out of 10. Do you say you can be in a 6? Do you try? I know those metrics are hard, but they're at least how we can conceptualize.
I always
everything.
say like you can be in mild to moderate discomfort. If
Okay.
you're doing a movement, it's severe. Well, then obviously back off. You know, you're going too fast. But so if we give them that education, and then I send to physical therapy or you guys as trainers, and why do I use you guys as coaches, trainers? Because you don't instill that fear. You're just trying to get them to move and function and reach the goal that they want, whether it's, you know, get up out of bed and walk to the mailbox or run a marathon.
Yeah.
And so that's what needs to be in mind with the end game of this.
So you have Dr. Lavelle who first touch, and you say you educate, and you say no, you need to move, no, we need to do this, so on and so forth, and then you kick it over. And Dusty, you see somebody who at least they get the first appeal to authority.
Yeah.
The doctor said, hey, you don't have to be scared of moving. That's A, and then we go over here to B. When you see somebody that's in that chronic pain state, how do you get them to overcome that fear?
Well, it's really important that when they come from him, that they've already been assured by
Huge.
the doctor, you know, that, hey, you can move. So we really just put the emphasis on like, hey, that's what we're going to do. We're going to train. We're going to move. The things that maybe you've been told, you know, don't bend over, don't squat. Those are the things that we're going to do.
Do you explain what moving is? Like, I know when people hear it, they, like you said, oh, it's okay to move is what like the general conception is, but they'll consider like vacuuming moving.
I went up and down the stairs twice today.
Yeah, that's probably not what we're talking about. Do you try to define it, or do you say what is your normal activity and then say this is what we're like? Do you try to already conceptualize it with what they do?
Yeah, I do try to give them like some understanding and perspective. And when you say you've been told, I don't need to, I shouldn't bend over. Okay, how did you get here?
Probably been over at some point in time.
Right. You had to get into your car, out of your car. Well, that involved some hinging at the hip.
Sure.
So you've already done the thing that you've been told not to do.
Okay. So you highlight that.
So in their mind, yeah, when somebody thinks, when they've been told not to bend over, they think like deadlifting, that's bending over, you know, and that is a hinge pattern.
Yeah.
But you're also, there was a stat that I had heard a few years ago that the average person hinges at the hip like 300 and something times every single day.
And I've heard up to 1,000 or more.
Yeah. So it's a very common, movement pattern.
Sure.
So it's just really reassuring them that, hey, you're already doing the thing that you're the most scared of.
Yeah.
You know, it's just you don't realize it. It's only when it's put in maybe on a pedestal like, hey, all right, deep breath, tight back, we're going to pick this weight up, is where it feels like something really big, but you've already done this.
So if you have that's an interesting point. So if you have an athlete who you're going to get tuned up, you're training Dr. Lavelle and you're going to go for a max deadlift and you do that.
Yeah.
You talk about bracing, the appropriate measure to pick up 9 million pounds. Okay, cool. Do you try to take all of that and then diminish your vocabulary and your perception of it so they don't think it's such a big deal?
Yeah, I think it all depends on the individual. Within a short time into the conversation, you get a pretty good idea of where they are and what they're the most fearful of.
If it's going to terrify them.
Right.
Like for me, he's like, John, these are only 5-pound plates. You can do this.
So it's really just, it's listening, and hearing them out in, like, I hear what you're saying.
This goes back to what you were saying, though, too, where the mood, everything they came in with.
But
so if you have somebody who hasn't touched a weight for 25 years, it's going to be very different from somebody who was used to weightlifting or so forth, or being in a gym, and then they're kind of returning to it.
Yes.
Yeah.
So I think what they've been told is avoid, avoid, avoid. So what we do is we attack, attack, attack. So the things that they've been avoiding are the very things that we're going to start doing. Okay. So if you've been told not to bend, guess what we're doing? We're hinging.
So first time in, Dr. Lavelle he's diagnosed, and he says, I don't see anything mechanistic. You need to go to Dusty, and Dusty's going to do X, Y, Z. Then I see you first day in, and I'm hurting, but I can do some things.
Yeah.
What do you have me do?
So I'm going to run through like an assessment,
Sure.
more of just a movement assessment. So having them doing different movement patterns, and then just checking in with them on, hey, how did that feel? Did you feel any pain?
Do you ever see that it goes awry when you ask somebody how do they feel?
It's a tricky, like,
Yeah.
I try not to put too much emphasis on feeling because it's an emotion, and sometimes those are
that's good.
that can be affected by, maybe your cat died and you're dealing with that, and then you had to come to the gym. So there are a lot of external factors that can be playing into how you feel.
That's very true.
And that goes, sorry to interrupt you, but exactly what I was saying. I mentioned how fear avoidance can induce that stress and depression. We didn't even touch on everything else in their life.
Right.
That increases that stress and
and that
depression.
decreases your capacity whenever you increase the stress. So
100%.
you would take that into account maybe, and I know as good as you are at it, you could probably do this without even talking to them. You probably do it naturally, where you just sort of read whatever they're giving you and then decrease volume or adjust whatever you have in mind.
And that part alone is just so different, like that somebody's taking the time to actually listen, hear what they're saying, validate what they're saying, but then also, giving them a plan and saying like, hey, here's what we're going to do. We're going to move your body, and we may do some of the things that maybe you've been avoiding or maybe you've been told not to do. We're not going to push into like deep pain, but if it's just mild to moderate, like John said, those are the things that you're going to immediately start to give them the tools and reassurance that, hey, we're going to move through this. I'm right here. I'm watching you move. The movement pattern is sound. We're going to do these things. And then at the end, that's where I kind of like really check in on, hey, tell me how your back's feeling.
Okay.
Or tell me how your shoulder's feeling.
So I'm doing whatever the exercise selection is, and I'm doing that, and I come back with something that says, well, it's uncomfortable.
Yep.
Do you adjust?
Yeah.
Do you?
I mean, it could be just I would say that 9 times out of 10, it is just a movement pattern flaw. You know, it's that maybe whatever the thing is, I've just been doing it wrong for a long time, and that the repetition of the movement pattern is what's causing the irritation or the aggravation. So even just that little tweak, cleaning up some of those movement patterns, squat, overhead press, whatever it is, that alone, it can really clear things up.
Okay. And now I've been in pain for, we would probably consider chronic pain, would we consider it 3 months?
Yeah,
okay. So
typically.
if I said it's 3 months, I'm in relatively the same amount of pain. I have flare-ups. What do you think? Where do you start me at in a perfect world? I say I'm an open book. I'm a tabula rasa. Like you just get a clean slate with me. How many times do you want me to come in?
I want you coming in 2 to 3 times a week.
Okay, 2 to 3 times a week. Am I going to? Do I condition? Do I weight train only? Does it change by person? If my goal is to get out of pain,
it could. Well, that's going to be the main. That's going to be the main focus is getting you out of pain.
So even if I say something down the road like, "Hey, I'd really like to get out of pain to do whatever," you're like, "That's great, but
let's get you there first."
Is out of pain.
I want to lose 50 pounds, but I'm in pain.
Great.
All right, let's attack the pain point first, because honestly, in our field, that's the lowest hanging fruit.
Sure.
We need wins.
100%.
So every day, every session, I want you walking out feeling better than you did when you came in. And so every time I can do that, then that's a win. And we just keep stacking the wins. And so as we get along the journey, I mean, typically within 2 to 3 sessions, if I can get you to come 3 times a week, I'm going to get you out of pain probably by the end of the week.
Okay. And now that's habituation that we're talking about, where we're getting a little bit more exposed to the thing that we were fearful of, but in a dose that we can tolerate.
And what's happening is there's a mindset shift because of you. Now I'm seeing you 2 to 3 times a week. I'm reaffirming maybe some of the things that you've been the most terrified of. I'm saying, hey, you can do this. I've showed you now how to do it correctly. And now that you've performed it correctly, you're starting to feel better. So you start to immediately see like, oh, this can work. Nobody said we even had lifted weight yet. We haven't even touched maybe a barbell yet. We're
Because
just talking.
when I'm scared, and correct me if I'm wrong, I could stop, I could pause, I could stop everything. I could run away or retreat from whatever I'm doing, or I could push into it, which is what you're talking about.
Yep.
Like I'm scared of being in pain. Cool. We're going to go up right to this door. And because you're willing to keep doing that,
Yep.
you kind of get like a little bit of a dopamine hit. Would that be correct? Because I'm pushing into it. Mm-hmm. And then that's why I start to feel better almost immediately.
Yep. And I think that's, that's where the biggest change is physiologically you've got a change happening in the body, but it's also this barrier that they've been kind of standing behind for so long. And maybe it's just the gym in general, but now you're starting to give them the confidence that they can do this thing that they're the most scared about.
Yeah.
When those things happen, I mean, you're like on the brink of changing somebody's life, and so you're challenging them to just think differently, rather than us avoiding everything and trying to figure out what we need to take away. We're actually saying, hey, let's do more. Let's do this.
Is there one movement that, let's say that I'm not local, I can't go see Dr. Lavelle, I can't come to you. Is there a movement that you typically see starts to lessen that fear response? Like every time somebody does a suitcase carry, they feel better. I mean, is there anything that you see that, man, that's a go-to? Most people feel pretty good concerning like a back, we'll say.
Yeah, glute bridge.
Yeah, glute bridge. Okay, what is it you think that makes a glute bridge feel a little bit better than something else?
Well, one is you're on the ground, so I feel like people they relax their central nervous system because they're now on the floor.
Okay,
they're not trying to move their body through space. It's a very very easy movement.
Bilateral glute
to
bridge.
Understand. Yeah, okay. Bilateral. Yeah. You're on your back. Your feet are flat on the floor. You're just lifting the hips up off the floor and just getting into a hip extended position.
Yeah.
And activating the glutes. Yeah. And so then even a lot of people have tight psoas, hip flexor, especially if you're at a desk job. So now all of a sudden
starting to get extension.
We extend that muscle, and now that potentially eases some of the low back pain that maybe you're feeling. But you're introducing that hip hinge, but again in a very, very controlled setting. So if it is that person that's like been told, hey, don't bend over. We just did it.
Yeah.
We did it.
Yeah.
And most of the time, the pain on that is very, very minimal, if any.
If any.
Sure. And so that's a win. Now we've got you moving. Mm-hmm. We've got some hip hinging.
Now I can start to movement stack on top of that.
Absolutely. Because
I've already sent the signal that movement's okay.
Well, and it gives you a chance as the trainer, to check in. Like, hey, tell me where you feel this muscular wise. Like, can you feel activation in your glutes?
A lot of times it'll be like, no, I feel my hamstring, or I feel this thing over here.
And sometimes that can be just changing the foot position. So it gives you a chance to evaluate a lot of different things, but again, it's a very, very relaxed position for the client.
What's my total time in the gym if I'm going to see you 3 times a week? What's the sort of time I can look at for that? Am I looking at 30 minutes? Am I looking at an hour and a half? Is it too much?
No, I think I would say 45 minutes to an hour.
Okay.
We can
What activities do you avoid? So, for instance, you said sitting. That might be just causing an issue. More, not that we're trying to demonize sitting, more because we're not moving at all.
Yeah.
So, would I not get on a bike because a bike is just sitting?
Avoiding in the gym or out of the gym or both?
Both.
Okay,
yeah.
so
maybe both.
That's where early on I'm going to ask the question of like, hey, what do you do?
Okay.
What's your work?
And if I sit at a desk.
Right. So then that's going to tell me immediately, we probably are dealing with some
we
need
to extend the hip.
Right. We need to get that opened up. And so that's one where I'm going to maybe encourage that, hey, how about every 30 minutes you get up from your desk and I just want you to walk around, maybe even hop down and do 20 glute bridges. And so just trying to, rather than sitting at your desk for 4, 6, whatever it is, hours, how about you get up and let's start to introduce a little bit of movement just into your day.
Throughout the day.
Okay. And then as time goes on, I might switch that. You know, we may go from glute bridges to squats.
Okay.
So you're not just doing glute bridges when they see you that one time for the next 6 months, and that's the treatment.
No. I mean, it may be a week. You know, we do glute bridges. We see how we're feeling. And again, it's all about the wins. It's like, I'm feeling better. Okay, well, let's move along. Let's introduce another movement pattern.
So I think
that's how neurologically you're curing that fear, because you're fixing how the brain responds. All those pathways we talked about, prefrontal cortex, amygdala, the periductal gray, which we didn't really speak about, which sends the inhibitory pain process to stop pain. All that then recovers as you start stacking those movements, and they start realizing, I can do this. That stress response decreases, that improved mood with the dopamine hit, norepinephrine, serotonin then starting to release appropriately again.
Yeah.
All that improves, and that's why with his movement, neurologically things are starting to improve, and that's why that pain improves.
Now, I think I get where we come from, where we see the thing that has happened. We go to move into it. We don't run from it. We do it intelligently. We don't try to spark a flare up of some sort. Okay,
Exactly.
got it. The thing I don't think that I asked is, if there's nothing mechanistically wrong, where did the pain initially come from that the fear could develop?
Good question. So there could be multiple things, and we'll kind of have different episodes on this. I think we should have one on each area, but it could just be a muscle strain. Maybe it was the psoas. They're sitting a lot at work, and that started to pull in the lumbar spine, because it attaches from the lumbar down
does
the hip.
it for long enough, and then I committed an
Got out of bed
everyday
quick,
move.
maybe,
Okay,
or
got it.
maybe it strained it or pulled that muscle. So it was building up in the background, and one simple activity may set it off. Or
So
maybe
it's not that I'm so weak I can't pick up a pencil. It's that, like you said, I've repeated this horrible thing 7 million times.
Exactly.
And then one more got me.
Well, and a lot of times too, just the disruption of that habit can a lot of times just clear it up. So now, rather than me just sitting for long periods of time, I'm getting up and I'm just walking. You know, it doesn't even have to be that you're doing any specific
right,
movement,
right.
but other than just moving. But it's the disruption that all of a sudden now you have. You're just changing. You're redirecting.
Is that interrupting that pattern? Like, I'm telling myself this narrative, but the getting up is like, nope.
Oh, 100%.
I changed that narrative.
Yeah.
I didn't really change anything in me.
Structurally, you didn't change from a musculoskeletal standpoint, but neurologically, you're putting that feedback in that now I'm getting up and moving. I'm not just sitting.
Yeah.
And now, so then does the fear go away first, or does the pain go away first?
Well, I think fear goes before pain.
Okay, so I'll move, and I
would
could even
agree.
have I could maybe have a flare up, but I'm no longer scared of it, and I'll probably come back a little stronger. And you would recommend, and I'm sure we've all seen, like, I'm doing good, I'm doing good. Then it's a little weird for a week,
Yep.
and then but I've got to that point to where I'm not really scared of it. Now I just kind of take the pain in stride.
Well, and that is a really, really critical point. Is where
Because
you're going to have that. Yeah, exactly.
happen.
We're not going to be pain free for the rest of our life.
It's gonna happen.
So we're really just training until we get that next little flare up. You know,
Let's describe that again. You're saying that the cost of being awesome, inevitably we're going to have a little bit of pain. We're going to do well, and then there's probably a chance where we're going to run into a wall or a speed bump, whatever you want
it's
to call
the
it.
peaks and valleys,
and then we're going to come out of that.
Yep.
And then
But the valleys are not as long when you're training.
Right. And you understand that, it's just part of the journey. Like, I can come out of this. I've came out of it before. And I think that's a really big opportunity that first time. So let's say you've came in and I've been working with you now for a month. You're pretty much pain-free. You're getting your life back. You're doing a lot of things that you haven't done in a long time. And then all of a sudden over the weekend, you maybe got out of bed. You were a little dehydrated. Who
Didn't
knows?
sleep good.
Right.
Whatever. Yeah.
And now you've pulled a muscle and you've got some pain. Well, immediately you're going to think, oh my gosh,
I'm right back to where I started.
Yeah,
Yeah,
here it
yeah.
is. I'm back to step one. And so you're probably going to even message me and say, hey, over the weekend, my back, it flared up on me. I think I'm going to take today off. How about I see you on Friday? And my response is going to be, no, I want you to come on in at your regular time, and we're going to work through this, because I know we're about to really, we're going to shift the gear. We've been in first gear and it's going pretty good, but now we got an opportunity to really kick this thing into overdrive, because now the buy-in is going to be even better. Yeah. Because you're going to think, that it was over and all what you just done the last month was gone. And what's going to happen is we're going to do that one session, and you're going to immediately feel better. The pain's going to go away a lot faster than it did to begin with. So now you're starting to build this resiliency.
But more importantly, you changed the whole outlook on your fear of I'm going to avoid into you're going to persist.
Because in the past, you've always shut it down. Yes, right. It's like, all right, here I am, back to square one. I'm broken. It's always going to be this way. I'm old. Whatever it is, that you've been told. But now we're doing the opposite of kind of what the pattern has always been. We've got to break the cycle, and so I think that's always it. I don't I don't mean it in a negative way, but I almost kind of look for that. That first time, because it's always the first time that's the hardest, because it's they had momentum, they were believing that they were getting better, and then bam, it happens, and so then they feel like it's all gone, and so you do kind of feel like you're back at square one, but your messaging, my messaging to you is going to be a good bit different than it was when you walked in, because when you walked in, I was being very delicate with you. Because I was I wanted you to believe, but in order for you to believe, I needed you to trust me to get the thing going. Yep. Now I've shown you that I can get you out of pain. Yep. I've shown you that you can do these things. Yep. And so now I'm going to say, do the thing. Let's go. Let's get back to training. We're going to move through it. We're going to adjust whatever we pivot, however we have to do it with, maybe it's the movement patterns that we're tweaking. Maybe we're going to find a different start position, one that is a little more tolerable. Yeah. And so, but they're going to start to again see that as long as you show up, you're going to get better. Mm-hmm. It's only when you stop showing up are you really headed down that pain path, and you're going to live in that world. So again, it's all about, building the confidence to where people believe they know, I've done this before. Yeah. I've been here before. I know we can get through it. That then it just becomes okay.
And it's a lifestyle change. They got to keep, it's a continuum of progress. So you don't fall back into that same trap, because that's easy to do. They'll work out start training with you. They'll be active. They'll be consistent, maybe 3-6 months. They're feeling good. And they don't always have to stay with you, but keep doing that type of routine. But there's a lot that will keep doing it. They'll be pain-free. And then, life got busy. Mm-hmm. They stop doing it. They get a flare up. Maybe it's a little different. Maybe it's the same, but they don't come see me. They go to the urgent care. They go to the primary care physician. Now it's 3 months again in pain, and you restart that whole cycle. And that's what we really need in healthcare, is to avoid, and that's why we're doing this, to educate people, is find that person that's going to support you through that journey, whether it's a physician, a coach, a therapist, someone that is knowledgeable in this area to keep it going. And really every healthcare provider should be knowledgeable in this. There's no need to shut it down once you've ruled out those bad things that may need acute treatment. Yeah. But keeping that continuum going, it's a lifestyle. It's not just we're going to get you out of pain for 3 months and you're good to go.
Yeah, it doesn't end. There is no stopping point. But I think you also have to understand that it's not going to be perfect, and nor does it need to be for you to be able to reach the goals that you have. You can be pain free. 90% of the time, you know. But just know that there's that 10% window. It's going to hit, and maybe there's just no good reason, you know. There's nothing specific that happened.
Or we just can't figure it out.
What do you call it?
We just can't point it out.
I mean, you've said back pain's like the ninth wonder of the world.
Yeah, I mean, it's everyone's going to get it. It's crazy, but you just got to know how to deal with it and avoid that neurological response. I think that's the biggest propagator of this, is avoiding that trap where the nervous system gets wound up or sensitized. And
watch who you're surrounding yourself with. Watch the message that you're sending and reinforcing, and then keep pushing into it.
Yeah.
Gentlemen, thank you for your time. Thank you for watching. Join us for much more where that came from. And when you get a chance, follow us on Instagram and YouTube at Back in Action Podcast.